Good afternoon, good evening, everybody. Matt Campbell here, and just wanted to welcome you all to Healthcare in Nova Scotia, What the Pandemic Has Taught Us. So as I said, my name is Matt, and I'm the chair of IPAC Nova Scotia. And on behalf of all of my colleagues at the Institute of the Public Administration of Canada, I'm very pleased to welcome you all here in your offices and your living rooms and your kitchen tables for what will no doubt be a very engaging and important discussion. This is the third installment of our speaker series on key issues in government and public administration. And each one of them is designed to bring together thoughtful, inspiring thinking from public sector leaders and practitioners. And we have some wonderful ones here with us today. We'll be taking your questions as well, so please feel free to leave them in the comments on YouTube, and we'll get to as many as we can in the latter part of the discussion. Today marks exactly 1 year to the day since we last gathered this brainy foursome for a discussion on the future of healthcare in Nova Scotia, and I think it goes without saying a lot has happened in healthcare. And in every sector and in every industry in the past 12 months. So we thought the anniversary made a perfect opportunity to reflect and take stock at just what happened and what lessons we can learn. Lastly, I want to acknowledge the support of Deloitte, our presenting sponsor for the series. Deloitte's been a longtime supporter of IPAC, both here and across the country. So thank you for your ongoing support. And without further ado, please let me introduce our very esteemed moderator for this evening, Mary Jane Hampton. MJ brings 25 years of experience in health system leadership as a manager, a policymaker, an advocate, and a consultant. And many of you know MJ from her Health Hacks column on CBC's Information Morning. And today, MJ leads a very busy consulting practice where she's sought after for her practical, down-to-earth approach to managing change and, of course, moderating panel discussions. Over to you, MJ.
Well, thank you very much. And yeah, boy, has a lot ever changed since we were together a year ago today. I have rarely left my basement in having meetings, which is certainly something that is very different for me. Yeah, I don't think any of us could have expected when we left that room a year ago that the world would have shifted as much as it has. And I think the things we'd like to probe together today, now that we have the opportunity to get the peeps back from the discussion last year, is just to talk about what we've learned, what's the big stuff that's happened, what's been the good, the bad, and the ugly. So I'm very grateful to be back with you and to have the opportunity again to moderate a panel of three of the people who I probably respect the most in the health system. So thank you very much for that. Maybe by way of introductions, although I'm sure that none of the people who are on the panel need introduction, but nonetheless, since Matt wrote introductions out for me, I'll read them because I don't want to waste this piece of paper. We have down in your bottom screen with the guitar behind him, and if things get slow, he will break into music, which is a good thing. We have Dr. Peter Vaughan. He is board chair of Canada Health Infoway, and you will know many of him as his previous role as the Deputy Minister of Health at the Department of Health and Wellness in Nova Scotia. Before that, he was the CEO of South Shore Regional Health Authority, and he's also served as the CEO of the Canadian Medical Association and has been an emergency physician, a family doctor, an entrepreneur, and, believe it or not, an RCAF flight surgeon, which is always the nice kind of surprise party trick factoid that I'm sure you pull out at the beginning of cocktail parties, which aren't happening this year anyway, so you'll have to hold it. Second, we have Paula Gallagher in the screen beside me. Paula is a consulting partner with Deloitte and responsible for the firm's public sector and health practice in Atlantic Canada. She has worked with hundreds of clients in Atlantic Canada over the last 20 years, specializing in providing strategic and operational advice in the public and health sectors. And we have Dr. Gaynor Watson-Creed. Gaynor is the Nova Scotia Deputy Chief Medical Officer, and she's also a public health physician and a dedicated worker and passionate advocate in the role of public health. She's also the co-chair of Engage Nova Scotia, which is an increasingly important entity in the conversations that are facing this province. So we're really grateful to have her leadership there. And she is Dalhousie University's Faculty of Medicine, and she serves as, actually, are you the chair of Engage Nova Scotia or the co-chair? And you have to unmute. This is the rule game.
Yes, I think I'm unmuted. Can you hear me?
Okay. Now I can hear you. That was just a test to see.
Yeah, no, all good.
So are you the chair or the co-chair of Engage Nova Scotia?
Chair of the board of directors.
You're the chair of the board of directors. Well, you see, we just promoted you. So there we are. Okay. So so thank you all for being here. I will probably, just in case I have any audio disruption behind me, I will probably mute when each of you is talking. So if there's a little delay, you'll just need to be patient with me. But I think if we could maybe kick things off, when we got together last year, we talked about the big things that were going to be facing the health system and kind of innovations in the health system. And Paul, I might go to you first to say, so in the year that we've lived through, hopefully we've got a few weeks left before we can actually say we've done it. What have been what's been the big learning that you've had this year that you'd throw out for us?
So I think there have been many, but if I step back, I think I might have to say that I and the health system have learned most about how to accelerate adoption of virtual care. And when I step back from COVID generally, and I think that it's fair to say that every person on the planet has been impacted by COVID-19, and I think most of those impacts have been negative. But there have been some positives, quite a number of them, I would argue. And I would say that one of the most positive impacts has been the accelerated adoption of virtual care. Now, I wouldn't say that acceleration has been all positive, and we can talk about that later. But on balance, I would say the advances in virtual care as a result of COVID-19 have been big and positive. So let me just start by level setting. And when I say virtual care, I use this definition: the direct delivery of care between a patient and a provider, or communication between providers regarding the care of a patient at a distance using information and communication technology. This includes, but is not limited to, telephone, video conferencing, text, and online resources. So that's hopefully we would all agree that is what is virtual care. And I'm sure many of you have heard the question asked, how long has virtual care been around? And I wish I could engage with everyone listening, but I'm sure there would be a wide range of answers. And the answer is actually more than 140 years since the telephone was invented in 1876. The first documented use of virtual care was in 1905, when a Dutch physician completed the first long-distance telephonic transmission of heart sounds. And then in 1910, physicians in New York City successfully transmitted a variety of electrocardiograms. But over the next century, we saw a very slow evolution of virtual care. And I think the first formal example of virtual care in Nova Scotia was the establishment of the Nova Scotia Telehealth Network in 1996, so almost 25 years ago. And I would argue that virtual care has advanced more in the past 9 months than in the previous 140 years, or at least the previous 25 years. And I appreciate that might be a bit of an exaggeration, but I've certainly seen data that suggests the use of virtual care has gone up by 3,600% in some jurisdictions. And let me give you an example of what we're hearing from frontline providers about the accelerated use of virtual care. I and some of my colleagues are working with a client in Atlantic Canada to help them redesign ambulatory care, looking out over the next 15 years. And the work was about to start in March, but it was put on hold when COVID-19 hit. So we started our work in earnest in September. And just last week, we completed the last of a dozen virtual focus groups with physicians and other providers. And we heard consistently, if you had asked me back in March if I could do much of my work in any way other than in person, I would have said no. I would have said the patient won't want it, they won't like it, they won't accept it. And I would have said it's not good quality care. Now, they're saying virtual care is good and maybe better in some cases than in-person care. They're telling us that it's improved access, especially for those in rural areas, and it's improved their responsiveness. And interestingly, it's also allowed them to shift resources to prevention and well-being. So virtual care is providing them with a really efficient method of making outreach to patients, and it's being used more and more for that. We heard that from physicians, from nurses, allied health practitioners across a broad range of clinical areas. And they now better understand which patient needs can best be served through virtual care, and they're using this knowledge to plan services in the future. So while it's not all good, I would say on balance, the acceleration of virtual care has been very big and positive.
Good. Well, thanks for that. There's a lot to unpack there, as well as not only virtual care writ large, but also to explore whether the Nova Scotia Atlantic experience has been similar to what's happening in other parts of the country, because I think that there may be some push and pull in that, but we'll come back to that. So, Gaynor, can I go to you next and say, so what's the one, this may be really painfully obvious, but what is the one big thing for you?
Well, so I'm going to squeeze into MJ, but I promise that I'll do it in a record amount of time. Because you invited the public health physician, so I'm going to always do what I do, which is I'm going to go big and then I'm going to go narrow. And so when I think about big, I think at the beginning of the pandemic, what actually worried me about our capacity to manage it was our North American attitudes. So watching the pandemic unfold in Asia and Europe, my concern was that our capacity to stop doing what we're used to doing, what we're feel entitled to do, what we are accustomed to doing would be low. And I'm surprised. I'm maybe not so surprised. I'm pleased, I guess, to see what we've been able to accomplish in the time since the pandemic began in January. So we have changed the ways that we get together. We have changed the ways that we work. We have changed the ways that we spend, all kinds of ways. And so there have been lots of negatives and lots of people who got lost in those changes as well. But in order to manage the pandemic, we actually did more than I thought we could do, and we did it faster than I thought we could do. And so, very much in line with the comments that we just heard. In particular, I think we've learned a lot about how our capacity to do that is very different than our neighbors to the south, which to me is fascinating. On the sort of more narrow scale, though, when I think about what public health may have learned, I think the pandemic has given us an opportunity to see what our limitations are and where our fracture lines are. And I would say that the limitations that we're recognizing are not new to us, but I think they're going to stick now. It's the type of thing that once you've seen it, you can't unsee it. And I think what we are seeing very clearly now is a limitation in our bench strength in public health. And so you will have heard us talk about capacity in public health. I think at this panel last year, I talked about capacity in public health, and everybody goes to resources and money, and that's true. But the end impact of that is that the complexity of this pandemic has been such that we have had people on a daily basis. You go from one new complex problem to 3 to 9. It's just an exponential number. By the end of the day, whatever that work day is, it feels like the number of problems that you're looking at and trying to problem solve around is massive. But it's the same people often who are trying to solve problem number 1 and problem number 2 and problem number 3 and problem number 9 and problem number 12. And so when all of those people are gathering up all the problems and putting them in the same place and trying to work them together, you can imagine that A, things get confusing, and B, people get exhausted and frustrated, and you just want to throw up your hands and say, there's no way we can manage all of this, and just sort of turn a clean page the next day and forget the whole thing. And so I think we're really seeing, all of the talk that we've had over 15 years in this province about what's needed in public health from a resource investment perspective. I think we're seeing the real limitations of it right now. And as hard as that's been, I think that's really important learning for us, because now we know what we need to, concretely, what we need to improve on.
Okay. Thank you. And Peter, you bring a completely different lens. You have different kind of circles that you revolve in. What's your big learning from this year?
I would say, we've done some research across the country. Some of it's not published yet. Some of the environics research that we've done has been published just recently. The appetite first of all, the appetite on behalf of the citizenry of this country, phenomenally accepting of virtual digital healthcare. 92% Canadians want to see virtual healthcare today. 84% say they would like to see the tools of virtual care to help manage their own health. And over 80% think governments should be investing more in digital technology. So there's a lot of appetite. That's a huge sea change, and I think you referenced in your preliminary comments, MJ. And I think Paula referenced the 19th century technology. The sad part is that it's the 19th century technology that most people were using to connect with their healthcare providers. That is the telephone and some means. So on the one hand, there's a real disconnect between what citizenry wants and what is currently available. The research that we're currently engaged in looks at the driving forces, and we've looked across the country. And those are social, technological, economic, environmental, and political. And there's a lot, I think, as Gaynor was talking, there's like 80 driving forces going on right now. So people are trying to sort of deal with a lot of what's going on. I think the real challenge for us is going to be what we do after the pandemic, how we come out of the pandemic. And I think that's what we should be talking about, is really what are we going to do? Because I think there lies both the challenge and the opportunity.
Yeah, I would agree. And, I think that a thread that holds all of this together is that the response to default to virtual care, if for no other reason than the social distancing public health rules that meant that we couldn't physically meet as easily, but even between patient and provider, was obviously a necessity is the mother of invention. I have, and I guess without being harsh, because I think it absolutely needs to be acknowledged, as Gaynor has said, that we have done in the Atlantic region and in Nova Scotia some pretty amazing things in response to the pandemic. it would also need to be observed that it feels generally that the health system itself is challenged to walk and chew gum at the same time. I mean, it's like, you know, pick one thing, but that's really the only thing that we can focus on right now. And had it not been for the pandemic, there wouldn't have been the focus on virtual care. I guess the question is, looking beyond the reality of the pandemic, what do we need to do to give traction to those good things that have happened? And to Gaynor's point, what are the things that we need to do to make sure that those who were already marginalized before a pandemic experience more of that during a pandemic, don't become doubly disadvantaged after a pandemic? So Paul, I guess, given some of the advice-giving work that you're doing, I might look to you for some wisdom in that regard. What do we need to do to give traction to the good stuff, but also be real about asking the difficult questions about the not-so-good stuff?
So maybe I will ask. Sorry, I'm hearing a feedback. Maybe I'll ask you to address the marginalized population, how we make sure that we don't widen the gap as a result of virtual care. But I'm really hoping that the old adage, you can't unring a bell, is true here. If we turn back the advances we made in virtual care, that would be such a tremendously missed opportunity. But I think that will happen if we don't address some of the fundamentals. And one of those fundamentals, I think, is remuneration of physicians for virtual care. I think that has been a stumbling block for a very long time. And, there were some emergency measures put in place during the pandemic to allow physicians to rightfully be paid for the effort it takes to provide care virtually, which may be different, but may not be any less than it takes to provide care in person. So I think that has got to be addressed. So there are measures, temporary measures in place. They'll run out at a certain point in time. That needs to be thoughtfully done. The technology's there. There are decisions to make. As Peter said, we don't need to rely on 19th century technology. So technology may have been somewhat of a barrier where things were clunky. There were major issues around privacy. Those are behind us if we make the right choices. So I think if we get over the remuneration and we choose the right tools, it's no more difficult really for most of us than using our telephone. And it is ubiquitous. So I would say if we do those couple of things, then we should be able to move forward from where we are rather than take a step back. But I agree 100%, we have to deal with the marginalized population. So curious to hear what Gaynor has to say.
Well, before we go to Gaynor, though, I will point out that the you can't unring the bell analogy is a good one, because the big innovation in the Nova Scotia system anyway has been the telephone. I mean, the innovation is that we've gone cordless, for goodness sake. We still use fax machines. So, I embrace the notion that we've accepted that there is a fundamental room for communication tools to connect patients and providers together, but I'm still not confident that that really says that we have embraced virtual care. We've just figured out how to use the telephone. And honestly, if that's as far as we can come in 2020, pandemic or not, that makes my head hurt. But we'll come.
Absolutely. So this whole notion of synchronous, asynchronous virtual care, if people are synchronous, in real time, telephone, video, and the like, and that really is the extent of what people think about when they say virtual care. The biggest change will happen when we move forward with asynchronous care. So again, the ability to communicate provider to provider, provider to patient in not real time. That I think will be absolutely game-changing. And then when we talk about virtual care, that also means remote patient monitoring. I mean, this is we are, as you say, talking about telephone and video, which is, so Peter, you're shaking your head?
No, I'm just agreeing with you, but this is not new, though. I mean, you're talking about remote patient monitoring. I've been to Mercy Hospital in St. Louis, which is not new. For 10 years, the whole hospital has no patients. They have doctors and nurses. They're monitoring and treating patients, over 200 patients every day, out in their homes in communities across the United States, and have much better metrics and much better outcomes, and can measure and monitor All of that value jargon that we talk about is real, and we're still talking about it.
I agree. But Peter, do you agree that the physician remuneration has been a fundamental barrier?
Yeah, absolutely. I think, we tried many years ago to try and, do little pilots in this area, but there's two things. One, there wasn't receptivity, I think, and there really wasn't any political will, and there's always fear of change. I think it's not certain yet that we're going to continue down this road. But I think that's hopefully we'll come to that in our conversation, because some of the research we've been doing across the country shows very different approaches to the problems going forward, and I think we need to talk about that from our Atlantic perspective versus the other parts of the country. I think what we're seeing is very divergent leadership approaches, and we've seen that even in the approach to the pandemic and the approach to how we're dealing with restrictions or whatever. Very different across the country, a hodgepodge, you might say. That reflects very different approaches in attitude, and very different zeitgeist, I think, across the country. There isn't one Canadian approach, notwithstanding our differences from the US, very different approaches across the country. So I think we're going to see very different end games coming out of this. So whether or not we will see the continuation of provider remuneration, which is a no-brainer, whether we see that continue or not, I think it's not for certain. It's not a given. So I think the whole conversation, though, needs to change from equipping providers to citizenry and the engaged citizenry. And I think that's what's happening globally. It's happened dramatically faster than it has in Canada. And part of that, I think, relates to governance and leadership. So I'm going to leave it there. I put a lot on the table for conversation.
Well, to Gaynor, though, I think, engaging citizenry is key, but people are impacted profoundly differently depending on where they started out when the story began. So, Gaynor, to you, what is some considerations that we need to be putting on the table here?
Yeah, well, a couple of things, and I want to bring it back to the virtual care conversation too, because I think it's actually a similar pattern. One of the concerns that I continue to have about the pandemic is that we're treating this, I think, globally as though it's a temporary event. And so I think our approach, for example, to the adoption of virtual care is along those same lines. We're treating this as a temporary event. I'm not sure that we're thinking about, so what's the step after? What's the step after that keeps the conversation and the implementation going? Similarly, for marginalized populations, I have a worry that we have seen some things about how different populations are impacted during this pandemic that we may not have seen so clearly if we didn't have the pandemic. Now that we've seen it, my worry is that when the pandemic is over, we'll all go back to our corners and forget that ever happened. And so, as we think about, for example, notions like pandemic recovery, and I know, I have some colleagues who are working in this space, we do need to think about, so what is it that we've seen that we actually need to stick with, not turn away from, and continue to work through until we come up with something that looks like, if we had to do this again, would we have the same patterns in place, or would we definitely, design something different that would be with us for the long term? So for marginalized populations, I had a fantastic conversation just almost by accident with the Association of Black Social Workers a few weeks ago in Nova Scotia. And the colleague that I was speaking with there was actually talking about the ways in which pandemic preparedness is taking shape for Black communities in Nova Scotia. And it's getting down to that, what are the structural needs in those communities that allow them to function during a pandemic or whatever the next crisis is going to be, whether it's another pandemic of a different sort or whether it's climate change down the road from that. Looking closely at those structural determinants is what they're doing. But that requires some tenacity that I'm not sure we've organized our thinking around yet. I think the same is true for the virtual care conversation. If we continue to treat this as a temporary event, we're going to miss the opportunity to change. And so for me, that's kind of the big push going forward that we need to take on, is sticking with this as a now 2, 3, 4 year event so that we make those permanent changes.
And can I add to that? I think I'm hoping that we don't look at the vulnerabilities that have been exposed through COVID and then just paper over the problems. So I think about long-term care and I think about the vulnerabilities that have been exposed there. And I hope we don't say, well, if we could just have every individual living in long-term care having a private room, we've solved the problem. Instead of saying, how do we care for that aging population? How do we think back to, how do we keep them in their homes? But I'm worried that we're just gonna just paper over and fix the problem without thinking long-term about what is the actual underlying problem that we're trying to solve.
So Peter, looking across the country, would you say that there are jurisdictions that are real stars in finding opportunities to put legs under the work that needs to step us beyond a pandemic?
It's a great question, and Jay, I think from our recent research, which will be published in the not too distant future, and thanks to Paula's group, Deloitte, for doing some of that heavy lifting. We've seen significant difference of opinion about what the future is going to look like post-pandemic. And I just want to preface this by saying that there's a lot that we need to think about in terms of the economy, because we have to start to think about the economy and economic development in health terms. It is one of the major cornerstones of health. But the people in the West Coast, let me start with the West Coast. Leadership in the West Coast, our research is indicating that people believe we're going to go back to fighting fires. We've always, not been able to sort out some of the issues around interoperability and privacy and some of the things we've talked about. In Ontario and Quebec, very different. There's a desire to just go back the way we were. So there's a thinking that we'll go back to the struggling with some of the problems we have with fragmented systems or a variability of technology and data maturity. People thinking that that's what's going to happen. Interestingly enough, in the Atlantic region, folks, the leadership, a wide variety of not your usual suspects, but a wide variety of health leadership believing that we need to transform how we do healthcare, which is interesting. And in many ways, because we face some of the most dramatic economic challenges and all the sequelae of that, the inequalities and all of those pieces that fall from that. So very different mix across the country in terms of how leadership are thinking about that. Now, it's interesting in Atlantic Canada because probably farthest behind in many ways, and some of it, to answer your question, furthest behind in sort of the technological advances. Nova Scotia was a leader 5 years ago. We had the first access to a portal for your health information. Gone. We don't have that anymore. Nova Scotia was a leader in electronic prescribing and getting on that. Nova Scotia is the only province that doesn't have electronic prescribing. One of the things that really took off across the rest of the country during the pandemic was the obvious need to do electronic prescribing. Nova Scotia relies on fax machines. So, I think there's a disconnect between what we have and what the leadership is saying what we need to do. And so I think that's a real interesting point for a further conversation. But I think if we were looking to where's leadership, Quebec is certainly pretty significantly ahead in many of the digital areas, as is Alberta, as is BC. Those would be sort of my three areas.
Would that line up with your take on the world, Paula?
I think it would. Yes. I think, and I guess my mind has also even gone to COVID response and vaccine management as I was hearing Peter respond. And in some cases, I see some provinces saying, well, we already know how to administer vaccines, so we're good, without acknowledging that COVID-19 is not, the vaccine for COVID-19 is not a typical vaccine. So the comment, I guess, would be we're seeing such varied responses across the country where you might think, because we're facing similar things, that the responses would be similar. And it's not based on size. It's not all the big folks. They're so complex. They have the money to do things. The smaller provinces. It is about leadership, Peter. And so seeing real variability there. and some disturbing things in Atlantic Canada, I will say.
Yeah.
Well, I guess to put a different spin on it, and I think I said this last year and got some cringe looks in the audience for saying it, but the truth is that as much as we say in Nova Scotia and Atlantic Canada that we want to be leaders, we really don't ever want to be first. And for good reason. I mean, it's a lot more comfortable taking the lesson from others. And I would pitch that perhaps, and I may be turning a silk person to, or from a sow's ear, but perhaps we're very well positioned to take advantage of the wealth of learnings that have been experienced over the last 9, 10, soon to be 12 months, and apply them to best practice in our jurisdiction, because there is no question that the learning has been accelerated. And while you're absolutely right, this technology is new to healthcare, but it's not new to any other sector, nor is it new to any of us as consumers of technology. I mean, we've been doing online communication, asynchronous communication since forever in every other sector, from banking to tourism to Lord knows what. So it's just new to healthcare, which means that we should be able to figure out how to accelerate the adoption curve by learning from that experience, but also learning from the health system application that that is going to be very well documented over the last year. What I would ask, though, and I think I asked this question last year too, and I have to ask it again, where is the voice of the patient and the consumer in all of this? I mean, we've got everybody else, every other stakeholder group in the system with somebody speaking purely on their behalf, be that physicians, any other provider, industry. But the poor old patient and consumer is kind of left taking up whatever everybody else is prepared to provide. And I haven't yet heard anybody really do a good job of unlocking that channel of communication. And I don't know who speaks on behalf of the patient anymore. I really don't. I would argue disease groups don't. They speak on behalf of the disease that they're championing. So where does the patient voice come into this in any organized way, do you think?
So I'll start, if you like. I feel the need to give credit to Eastern Health in Newfoundland and Labrador. In my experience, they are the most innovative health authority in Atlantic Canada, and a lot of my colleagues across the country who have done work with Eastern Health will say the most innovative health authority in the country. And I've heard the CEO and others say repeatedly, someone has to be first, why not us? They are a living lab. They have opened their organization to provide data and access to clinicians to try things for the very first time. And without exception, they make sure that the patient's voice is part of that. So they have embraced innovation in a way that it's not just tacked on to something else. It's not just the buzzword. It is embedded in their culture, and they are doing some things with us and others that have never been done in the world. And they're a model for the rest to watch.
Yay them.
Yay them.
Peter?
So
Sorry, go ahead, Brandon.
Yeah, I think it's a fair question, MJ, and it's interesting. You know, sort of what I've observed during the pandemic is that in so many ways it feels like an unprecedented event because of the degree to which the public at large can participate in the pandemic response. And they are, in that they're participating through social media, they are participating in conversations with their elected officials, they are letting their preferences be known, at least on the pandemic response. With respect to the healthcare system, though, and I think public health, again, similar, I think you're right that we've not deliberately tapped into that perhaps the way we could. But again, I feel like this is where the limitation of our thinking will be in thinking of the pandemic as a temporary response. And right now what's happening is everybody's just trying to cope even in Atlantic Canada, with a relatively few number of cases compared to Western Canada, everybody's just trying to cope. That's in an acute care and in public health. And so the notion of layering on, the additional thinking that takes us beyond the pandemic into a new future, quite frankly, I think right now is just escapes us. I had a conversation with a colleague yesterday from Toronto Public Health, and the first question I asked her was, how are you doing? And every time I ask this question or hear it asked in a meeting this year, I always get only a noise in response. The noise sounds something like, ugh. And everybody is like that. It doesn't matter if it's in a meeting about acute care services, if it's a public health meeting, if it's a national meeting or provincial meeting, it's always the first thing people respond with. And so I think that, some of our inability to tap into, for example, the voice of patients, innovation is in part right now due to our level of exhaustion. I don't think we get over that by continuing to treat this as a temporary response. I think we actually have to pace ourselves in a way that gets us into a more forward-thinking, future-thinking look at what we do from here.
Yeah, I think I think Gaynor's right. I think traditionally, MJ, in this country, primarily we've looked to government. The ones who represent the citizens' views of what people want in healthcare. I'm not sure and this is not a political statement, I want to make that very clear. I'm not sure we have much of a government right now. It's sort of there, but it's sort of absent. This is not a criticism of anyone in particular, but I think there's not an active government leadership beyond what shows up on YouTube or Facebook or the television page. There's not a sense that in terms of how we're going to retool maybe if we
Are others experiencing the same problem and unable to hear Peter?
Yes, I think Peter just froze up. Is it just Peter? All right, well, maybe let Peter reset himself, and figuratively speaking, not. But I think I think the point that Peter was making is a fair one. Again, I would maybe offer a flip side, though, to say that I would also observe that one of the things coming out of the pandemic is a much, how would I put this, a much more sense of visible leadership in the health system than we have seen in a long time, of necessity. And it's not, I think that Rob Strang has done an awful lot to advance that. But I think even as, I would hearken back to 2 years ago and some of the overt hostility that would have been expressed with respect to health authority and even, Department of Health and Wellness, that's really, really settled itself down in many of the circles that I would observe and engage in. It feels more like everybody has embraced more of a solution-oriented, engaged, collaborative approach to stuff. And, crisis does that, and that's a good thing. But that's, I think, one of the other things that I would hope to build on Gaynor's sense of needing to move out into the future, understanding that the present has been fundamentally changed. I hope that that's one of the things that we take into the future, because that real animosity and hostility that was palpable 2 years ago, I'm not seeing that now, and I'm glad not to be seeing that now, because it was toxic, and I found that actually more exhausting than I found the pandemic. So I would just put that out there. Sorry, Peter. I think you're back. Did you want to finish your thought?
Well, I probably did, and you couldn't hear it. So.
And it was brilliant. It was freaking brilliant.
It was really good, but
it was. That was the best part.
We'll move on. We'll move.
So I guess I did have a question for Gaynor, just based on what you've said, MJ. Gaynor, you talked about the lack of bench strength in public health. Do you think that this visibility and the leadership that we've seen from public health over the course of the pandemic, do you think that has raised the visibility of the importance of public health and the lack of bench strength, and might that be corrected?
Yeah, I can only hope so, Paula. I mean, so prior to the pandemic, there were a number of us across the country trying to sound alarm bells around the state of public health in Canada post SARS. So looking back at that outbreak as an example, and a Naylor report and the recommendations that were meant to be instituted, there are many of us who would agree that we never completed the work on the Naylor report, and which is now 15 years old. And so 17 years old, actually. And so, we have at national forums and in conversations with, for example, national senators, really been trying to raise the alarm that this is serious. So I think the bench strength is, a symptom of that, that failing of the public health system that we were starting to signal even 4 and 5 years ago. My hope is that post-pandemic, we will start to see a renewed interest in examining whether or not, in fact, we were meeting the mark pre-pandemic, and what we need to do to sort of position ourselves better for the next public health crises, which, again, I don't think are going to be pandemics. I think if we think COVID-19 is complex, I think the one that is going to stymie us all is going to be the impacts from climate change, which I think will be slow and insidious, but also unrelenting. And we have to get ready for that one, and public health needs to be sort of at the forefront of that. And I worry that if we don't pay attention to the public health system, we won't have that. So I hope that we're going to see that type of attention. On the other hand, I do look at a province like Nova Scotia, little Nova Scotia, and I think about where we've been in the past 9 months, and I go, what's interesting is we, even though we don't have bench strength, at those very early press conferences when, I was there for the first one and the first couple, and certainly Dr. Strang and the Premier was there and the Minister of Health was there. And what I kept remarking on was, if the table could have been longer, if there was more room in that media briefing room, you would have seen, to MJ's point, our director of lab services, you would have seen our health system CEOs at NSHA and IWK. There were multitudes of people in the background who, I'd watched the press conferences from Ontario in those early days, and they were sort of showcasing the depth of their team. And it did feel like, and still feels like, we do have at least the bones of the team that we need. And I am a little bit sad that we've not been able to showcase that better. Because that has been a real strength. And I think you're right, MJ, to point to the ways in which the health authorities, and I do say multiple health authorities and the department have come together on this and found their role and their lanes and are working through some of the problems together, as difficult and exhausting as that has been. So we have that, I think, to look to as a positive as well.
I would just say to everyone who's listening, if there are any questions that you want to throw out, we would be happy to take them. I'm more than happy to continue chatting with my friends, but if there is anything specific you want to throw into the mix, don't hold back. We will be glad to welcome anything that you want to throw our way. I think if we look post-pandemic, and I have said several times that it's always felt like COVID was just a dry run for something else. And Gaynor, I think you're probably right. It will be something more like the impact of climate change or something equally big and insidious. I think that, the tectonic event of COVID is something that we will have got our legs under us, but it's a dry run for something bigger. And I think looking practically at, this time next year, what would you hope you would kick off next year's panel saying that we did really well? I mean, so we've talked about the one thing that we've learned, but when we come together on December 3rd, 2021, God willing, what is the one thing that each of you would like to say we've done, in retrospect, we did really well?
So I'll jump in while I still
Sure.
have an internet connection talking about technology, I guess. I would like to pick up on your earlier theme, and I think we'd like to see a real citizen view of healthcare, not a health system view of healthcare or a government view of healthcare, because I think we have to move beyond thinking about government as a government problem. It's not a government problem. We need to think about new alliances. So I'd like to see a new alliance that really is driving a citizen's view of healthcare. But for all the things that we've just been talking around, the connectivity, over 80% of Canadians want to share their health data, their anonymized health data. But the worst case scenario is we just go back to normal, which is what we all want to do. And so I think some sort of a vision, a citizen-driven vision, a new alliance is what we need. It's not just government's problem.
Yeah, I might jump in from there, because I think if I had to think of specific citizens, I would think of marginalized citizens. And so I'd want to see, folks from those underrepresented groups more firmly at the table. On that note, I think the one thing that we have done well in the province of Nova Scotia, we're not quite there yet, but we're at least having the right conversations and putting in place the right mechanisms, is race-based data collection is coming to the province of Nova Scotia. So in part because of our input, this has now been a national initiative for COVID. But I think it will extend beyond COVID in the months to come, and that allows us to finally start to look at where are the disparities in health outcomes that we should have been looking at all along, and then making steps to resolve them. So I would hope that a year from now we could say concretely that we've actually made the right moves in that direction.
And I agree with all of that. I will add, hopefully we will have had a very successful vaccination management program. That's a fear of mine, and I hope in December we will say that has gone well. It won't be over, but it has gone really well. And I do hope that some of those really serious vulnerabilities that COVID has revealed, and for me, one of them is public health. I hope that we say public health, the important role of public health has been recognized. We are investing more in public health. We've built the capacity we need there, so that would be one. And similar to the racialized, marginalized population, I do hope that we take a step back and think holistically about how we deal with our aging population. That's a lot in a year, but hopefully we've started on the path to some of those fundamental changes.
And so I have a question from Nicholas Chamberlain, and he has asked, what do you believe is required to move forward from temporary to more long-term solutions and approaches to COVID-19? What are some examples that you would all like to see? Gaynor, do you want to jump in first?
Yeah, I think some of the specific examples have come up around, sort of everything from how we deal with virtual care going forward, in terms of what concretely could take a more long-term trajectory. Paula's raised immunization. I've raised, our approach to marginalized communities and data collection in the health system there. But I think in order to get there, we probably do need to have some of that bench strength deepened. So I feel like the same people who are kind of on the front lines of managing the current pandemic, and that includes our hospital executives and CEOs, can't also take on the work of changing us to a new future right now. I think they need to be alongside that. I think they need to be champions for it. And I think they probably need some additional folks in that future-oriented space with them in order to get there. So I think the bench strength to get us to the future is some of what we need to address.
So maybe if I can add to that, I wonder if we could take the time to identify some of those short-term emergency changes that we've put in place. And there's one, I'm not entirely sure this is true, but I think that employees no longer need a doctor's note signed by a physician if they're unable to work. Well, we should never have needed doctors to sign a doctor's note for that. So what are those things that we stopped doing during the pandemic temporarily? Let's inventory those and let's figure out those things that should be stopped permanently. They're small things, but I think we've gotten rid of a lot of redundant, duplicative, low value activities, and let's not allow them to come back.
Yeah, I think that's very sensible. Next question is from Kevin McNamara, and Kevin has asked, what can we do to provide additional support for folks under major stresses, losing their job, entrepreneurs losing their business, or working with less staff to keep afloat? And I think that points to the other really great reality of what the year has thrown to people. So I don't know. Peter, did you catch that question?
I'm just reading it now.
It is so ironic that you would be the one challenged by technology. It's that guitar. That guitar is sucking something from your internet feed.
Yeah, I don't think it's my guitar, but it's a great question, Kevin. I think that we've got a lot of issues with the economic development issues and coming back, bringing the economy back. And I think that's going to be one of the major challenges that society, not just government, but we're all going to have to get our heads around. The longer this goes on, the harder it is for people. And we haven't even talked about mental health and stresses and social distance and family and all of those pieces.
He's got to get rid of that guitar. I would just ask the broad question, though, given the bucket loads of money that are being thrown at healthcare to deal with the pandemic, given the bucket loads of money that are being thrown to various social unemployment programs, all which would appear to be necessary investments, is there a risk that as we come out of pandemic spending, that all of the other things that we were hoping were going to be new health system priorities, like pharmacare, like investments in mental health, like the investments that need to be made in long-term care and care of the aged, are we going to find ourselves? Oh, we got a big feedback, I think. Are we going to find ourselves in the position that COVID has broken the bank and that we have all of those other really important health system transformations and modernizations off the table? I mean, there's a big investment we need to make in public health. There's a big investment we need to make in a drug program. Have we spent ourselves through COVID that we're not going to be able to do any of that stuff?
Yeah.
Well, so this would be my worry, MJ, and I would say, in my case, it goes beyond healthcare. So again, when I come back to those structural determinants, I feel like Kevin's question is pointing us to the place of what are the other sort of extra sectoral outside of healthcare policy opportunities that have been opened by COVID. So where we are directing our spending right now really matters if we want to get underneath, for example, guaranteed basic income, or if we really want to get underneath housing as a determinant of COVID outcomes and not wanting to live through that again. And so I'm less worried that we're going to spend our way out of health system improvements, and more that we're going to spend our way out of the bigger societal improvements that we actually have had our eyes open to during COVID. I think we need to pay attention to make sure that we don't lose the opportunity, the policy opportunity that those are opening.
And I do hope that we fundamentally change the way we work with the private sector and not-for-profits to do that. And we need to be paying for outcomes, stop putting money into those traditional areas. So I think there's always a fundamental question about whether we have enough money to address some of these issues if we spent it differently. So I do hope that this, that don't waste a good crisis, we're at that point. And I worry that because we're going to continue doing what we've always done, and then we're looking for incremental money to do the things that we need to do instead of rethinking what we do and how we pay for outcomes instead of activity.
I just broke the rule. Sorry. Anything you want to add to that, Peter? Or not?
Yeah.
I'm going to give us one last question, and then I think it will be it for our forum. Do you feel that payment models and policies are effectively incentivizing providers to leverage virtual healthcare technology? And maybe, Paula, I'll let you take a run at that. And if Peter comes live again, we'll sneak him in before he freezes.
So the short answer is no. I mean, we could just stop there. And I really do believe that that is one of the fundamental barriers. So we have providers who need to be incented to adopt primary care. And then Peter has talked about the citizens. And what we've seen is tremendous movement in terms of citizens accepting and willingness and attitudes about that. And providers, I think their attitudes have changed as well. But it is unfair to expect physicians to provide significant amounts of care without being properly, not so much incentivized as remunerated. So I think, and especially fee-for-service physicians, so the payment models and related policies, they need to be thought through in the long term, because all we've done is we put our fingers in the dike, but we have not solved for this in any way.
We could probably spend a whole panel talking about that, and somebody should, because those really, that is one of the big policy issues of the day. Peter, anything you want to add to that?
Yeah, no, I just, obviously it's frustrated with the technology here today. Not normal. I think we have to change our thinking. We have to change how we think about healthcare delivery. I think this is the opportunity the pandemic gives us, and all of the things that Paula and Gaynor are talking about are absolutely true. But we're not, the policy issues, the governance issues are the major issues that we have to confront. And it's not just about paying doctors more and paying them, to do virtual care. We have to change the process. It's not about digitizing the form. It's not about faxing the form. We have to change how we do healthcare, and that's what digital technology really allows us to do. So we really have to get our heads around reimagining that future, our thinking, our processes, our organizations. These are the real opportunities. But there's going to be a lot of challenges. About 80 driving forces that coming at us every minute right now, and it's not necessarily a given. I hate to be lugubrious, but this is not a slam dunk that everything's going to get better, because the natural inclination is to go, let's just go back to the way we were, I'm happy to just go back. And I don't think history tells us that we actually can go back.
Well, either you can't unring the bell or you can't put the toothpaste back in the tube. And yeah, you're quite right. Gaynor, last word to you.
Yeah, I don't think I have anything to add. I think Peter's hitting the nail on the head, in that if we think about this with the same thinking that we have had up until now, we'll just think ourselves back to the way we were, and where we want to go is somewhere entirely different. So new thinking is needed.
So Gaynor, do you think that December 3rd, 2021, we're going to be able to sit next to each other in a panel, or am I still going to be in my basement?
If you're not in your basement, you'll have a mask on probably wherever you are. And aside from that, I make no promises.
Well, I think just to be safe, I may invest in a renovation that gets me away from the pipe that every time someone flushes the toilet, I don't sound like I'm in front of Niagara Falls. So just saying. You guys have been absolutely fabulous. Thank you. It's so nice to see you. I've missed you, and I would wear a mask to be in your presence. But Cynthia, I think maybe I'll hand it off to you to wrap this up, and I will thank all of you who've been with us for the last hour. Thank you for patching in. It's nice to feel your presence, even if we can't see you in person, but maybe December 3rd, 2021 we can. Cynthia?
Well, MJ, a big thank you to you also for moderating our conversation today. It's been really great to hear the questions and the input from all of our great speakers today as well. Sharing the lessons learned and then where we're going to go next and the opportunities that have presented themselves is kind of exciting while we recognize all that we've been through in the last few months as well. So I first just want to send a quick thank you out to our organizers, Mona and Jocelyn, who put this event together. So thank you to them. Also to Gaynor and Peter and Paula and MJ again, thank you for joining us and for all your insights. And I'd like to remind everybody who's on the event today to go Google IPAC Nova Scotia and get your membership. We'd love to hear from you and have you at our events in the future. And speaking of events in the future, on February 3rd, we have a really interesting event coming up. It's a fireside chat with Dr. Carr, and he's going to reflect on his first year as CEO of Nova Scotia Health. So that should also be a great conversation for everyone to be part of. So thank you again, everyone. Have a good evening and be safe.